do want to go live.
Megan has her thing at the exact same time as our first year's, but
Well, I scheduled ours before she put hers out.
that's true.
And I was like, dude, what am I supposed to do? Hey, let's cancel everything. Do want to go live. Oh, there we go. I don't want to hear me going live. Well, I scheduled. There we go. Now I'm shut up. Damn it. Okay. So we got just a couple of minutes. Hey, I'm going to put up the slide deck, Jocelyn, so you will know that's where I'm at. Okay, is the slide deck up?
Yep, I see it.
Okay, cool. Okay. And thanks for your feedback on that receptor thing. There's just so many different ones.
Oh yeah.
I had to cross the bridge somehow.
No, you're good. I just wanted to make sure we were all on the same page.
No. Well, I was like, I did this at 11:30 at night. Let me make sure somebody else sees it. I'm not going crazy.
Right.
God forbid. I mean, I can certainly screw stuff up.
I was like, I can't find them.
Did you find them now,
Yes,
Mindy?
I did. I went back to the PowerPoint that we used for the first.
Okay, yeah,
first week.
because I can't remember anything more than a day, so I had to just put it on the website. Yeah, hey, Jocelyn, and I will just download the link to this YouTube on the website, okay?
Sounds good.
And the link to the website is on the PowerPoint here, and I'm going to start downloading the links to these PowerPoints to the website as well, so other people can get to the PowerPoint if they want it as well.
Okay.
We won't have to like give it out to people. They can just go to the website and download whatever they want.
Yeah, that's nice. Okay, sounds good.
That's why I have a website, because then it's a receptacle that
Yeah,
we can put everything, and people can find what they want, and they don't have to. Because I'm, we're all in nursing school, like,
Yeah,
so,
it's like a little cloud for
yeah,
everything.
it's like a little cloud of our own stuff. Okay, cool. And if you guys want to join Jeopardy and come watch Jeopardy and play along as a home viewer, you can. The link is on the website. So just go to the second semester link for This is Jeopardy and jump on, and it'll be awesome.
Yeah, but I think it'll be good to see like what kind of stuff you guys are learning in second semester. So.
Well, and I was looking through the questions that I had, and a lot of the stuff you guys already know.
Sure.
You can watch me play, everybody.
I was gonna say
Mindy's a participant with Tyler and Gabby.
Oh, okay.
You guys don't know Tyler and Gabby, but Tyler's the CSC president.
Yeah.
He's the co-president with Emily, and Gabby is our cohort rep.
Oh, okay. Gotcha.
So I basically just finagled all the CSC people I knew to be in our cohort group.
Nice.
Okay, so you guys ready?
Yeah, let's get started.
Okay, oh, we got a pretty good group tonight. Okay, hold on. So here's the agenda. Welcome. Just the one announcement is that the final OSCE review and practice, there's a sign-up sheet for that. It's on the website. The website address is right there. So if you still want to get involved with the OSCE head-to-toe final practice before your OSCE and foundations, there is going to be one. And Morgan and Kate, is that who? Haley run that one, but we're probably going to help them. So
yeah, I think that's on the 20th, right? Like
it's coming up like a Tuesday, yeah. And it'll be here at the school in the lab, which will be awesome. I don't know how they swung that, but they swung it. So you guys will have.
If you want to do it, make sure you sign up because they have to get enough people. So make sure you sign up.
Okay, then we have
when do we need to sign up by for that?
I will ask Morgan and Haley. They didn't put like a set time, but I just saw the list the other day and there's not too many people signed up. But I'll get them to publish a day that they're going to like a drop dead day. And then I'll make sure everybody, at least in our committee stuff, I'll put it out.
Okay, thank you.
Okay, so we're going to hit receptors tonight. And I told Kat that I would do that. And then O2 delivery is going to be Cassie, who I believe is Casey.
Yeah, Casey.
And
Casey's
Casey
a member of our education committee. So
Casey is joining the education committee. So awesome. And then drug review, Jocelyn has got an awesome Kahoot for you guys. And then most likely Jocelyn will be running the closing and then scheduling your next meeting. If it's next Monday or whatever, I will leave that entirely up to her. And then we'll get you guys set up for your next review. Is that cool?
Sounds like a plan.
Okay, so really quickly, so Kat asked like 2 weeks ago or 3 weeks ago to go over receptors. And one of the things as I was looking through this is there's actually quite a bit of receptor material here. And so there's not, I mean, that's like an hour-long class in your CM that your teachers took to cover this. So all I'm going to do is I'm just going to kind of show you a method of like one set of receptors. And then we're going to talk about when you see drugs or something and you don't know the receptor pathway, how you go look that up, if that makes sense. So looking at the receptors that deal specifically with the central nervous system and the big ones that you guys are kind of really covering in CM1. So the nervous system is broken down into two parts, the somatic system and the autonomic, or I put automatic here, but the somatic covers all of the controlled things. So all of your skeletal muscle that controls movement that you have voluntary control over is on the somatic side, and cardiac a little bit. You know what I mean? Like you can do things to that and hold your breath and stuff, but it's not truly somatic. Okay. It's mostly covered in our autonomic side. And then your autonomic side is broken down into two sides. So the SNS and the PNS. And then the little tags under those are, let me see my pointer's working. So fight or flight is one of the ways that we can say SNS, and rest and digest is another way of saying PNS. So here's my parasympathetic nervous system's PNS, and sympathetic nervous system is the autonomics, is the fight or flight side. Okay. The next way to say each of these is adrenergic and cholinergic. Okay. So when I say, hey, this drug is an anti-cholinergic drug, it means it's saying I'm going to try to shut this side down and I want to push us over to this side. Because in these receptors, only one side of the system can be active at one time. So if I'm in my fight or flight response, that means my rest and digest side is not active, and vice versa. And there are things about these two systems that we want to work and to be appropriate while we're trying to, go about our everyday lives. Okay. Now the three kinds of neurotransmitters that deal with SNS or sympathetic nervous system is epinephrine, norepinephrine, and dopamine. And the one that's over here on the PNS side is acetylcholine. Okay. And so you'll notice, again, in looking in your drug cards, you'll see drugs that say, oh, this is an acetylcholase inhibitor. It won't say cholinergic or adrenergic. It'll talk about the specific drug. It'll talk about a specific receptor, or it'll say, parasymphomometic is another word that they'll use, which means it mimics the parasympathetic side. So there's a lot of different ways that the drug cards can say, this is the receptor pathway that I'm on. Okay, now coming over here at the design that I have here. So skeletal muscle is the somatic motory system. And so the CNS is the spinal cord in the brain. And it's just a straight shot, right, to the skeletal muscle. And then there's the pathway, right? There's my receptor pathway. I have a nicotinic receptor right there, okay? And it is being stimulated by what thing? Can anybody tell me what neurotransmitter is being transferred there? Bueller? Okay, so I'll help you. So the little letters right here says ACH. ACH is here. So what pathway is being stimulated here?
Parasympathetic.
Yeah, this one's a little bit of a cheat because look, somatic control isn't Kaylee or Casey? It's not done in the autonomic side. I was cheating you. Acetylcholine activates and is the neurotransmitter for the somatic side, but the somatic side's under voluntary control. It's over here, okay? But now let's come over here. So what does it say right here at the very top of this line?
Parasympathetic.
Yep, it says parasympathetic, right? So what's another way that I can say parasympathetic?
Cholinergic.
Cholinergic, excellent, good. Okay, and I can also say rest and digest. I should be thinking all three of those when I see any one of those things. The other one should come to my mind, okay? Now let me ask you a question here. How long is the neural receptor here before it reaches its synapse, its first synapse? Is that long or short?
Long.
Okay, so parasympathetic nervous actions are controlled by long preganglionic nerves, right? To the first receptor, right, or the first ganglion, right? Nicotinic receptors. Acetylcholine is the receptor transmitter. And then how long do I have to go before I get to the effector, the organ or the next neuron that I'm trying to reach? How long is the post presynaptic neuron? How long is the post, the next one? The secondary one. It's quite short, right? So I don't have to go too far to reach that target organ in my parasympathetic system, okay? So that's one of the things that this pathway, you should remember, that parasympathetic pathways have a long first connection and a short connection to the organ or the effector area that we want to get to. And the first receptor site is called what? The first pathway is nicotinic, and the second receptor site is called muscarinic. Okay, so remember those because you're going to have drugs that say, "Hey, this drug is a muscarinic receptor inhibitor." Okay, and if it says that, if it's a muscarinic receptor inhibitor only, which pathways can be affected by it? Can my somatic system be affected by a muscarinic receptor inhibitor?
No.
Why not?
It's just the nicotinic receptor.
Yeah, there's only a nicotinic receptor pathway here, and so I can't block that with a medication or inhibit that one at all, right? But what happens if I get a medication that is a nicotinic inhibitor? What am I inhibiting? I am inhibiting skeletal muscle. Look right here. My first synaptic pathway in the parasympathetic is controlled by what?
Nicotinic.
A nicotinic. Well, look at my sympathetic pathway. Even though it's shorter from the central nervous system, right? My first neural response is shorter. Look at the name of the receptor there.
Yeah, you also have a
Nicotinic receptor, right? And so if I take a nicotinic inhibitor, I inhibit everything. I inhibit the somatic system, the parasympathetic system, and the somatic system. Does that make sense? Or the sympathetic, sympathetic system. Okay. Now let's look at our sympathetic system. Our primary neurons coming off the spinal cord are long or short?
Short.
They're short, right? And then I get to jump right here. That's a nicotinic receptor controlled by acetylcholine, right? And then I get out here. Now look at what my receptors become. I got this long neural pathway. What does this little character right there stand for? It's Greek for something.
Alpha.
Alpha. Excellent, Casey. That's awesome. Then what's the other one controlled by?
Beta.
Beta. So I've got my alpha and beta pathways in my sympathetic pathway. Now, can anybody tell me what alpha and beta receptors control in the sympathetic system? What do we traditionally know those for? And if you don't know, it's okay. We're going to go over it right now, but I'm just seeing if anybody knows them. Well, let's come
Sorry, Chris. Could you say where's the alpha and the beta were again?
So alpha is right down here. Can you see that, Nicole, right here?
Yeah, I can see that.
My final receptor to my afferent organ or my target organ, I have an alpha receptor, and I can have a beta 1 and a beta 2 that's on a different line. Okay. Do you guys know what any of those are? So let's look over here. What does our central nervous system do for us? Or I mean, our sympathetic pathway. What does this put us in if this is active?
Fight or flight.
Fight or flight. So my alpha receptors, traditionally, my alpha receptors here, they control, and I'm going to say this with like a mnemonic that I learned: can't see, can't spit, can't pee, can't poop. When that alpha receptor's activated, my eyes start to dilate and get more active because I'm trying to bring in as much light as I can because I got to punch somebody or I got to run from the bear. Okay. I can't spit. My mouth starts to get dry because that alpha receptor says you don't need to be eating or drinking right now. So we're going to shunt that energy from our mouth and our digestive system to other areas of the body so that we can run from the bear. Okay. Then I can't see, can't spit. What else did I say? What was the next thing?
Can't pee.
I can't pee. And so that alpha receptor is going to stimulate our urinary system to say, hey, it's time to run, not pee. And so it's going to affect the kidneys and the urinary system to control that. And the last thing that it does is tells us to do what?
Can't poop.
Not poop, right? Our GI, our defecating system is going to shut down and not work either, because when I'm running from the Tyrannosaurus Rex on Jurassic Park, the last thing to be doing is to be hiding in a porta potty, right? You need to be running from the Tyrannosaurus Rex, okay? Well, if that's what the alpha receptor does, then what are my beta 1 and beta 2 receptors going to be doing for me?
Isn't beta 1 the heart and then beta 2 is the lungs?
Absolutely. I have one beta receptor for the heart because I have one heart. Excellent. And I have 2 beta receptors going to my lungs because I have 2 lungs. And so what kind of things, Casey, am I going to want my heart and lungs to do if I got to fight the Tyrannosaurus Rex? What do I want to be happening?
You would want your heart to pump more blood through your body so that you could get more blood to your muscles so that
Excellent.
you can move faster.
That is exactly true. So my heart rate's going to go up. I'm going to see hormones and things being secreted that increase my cardiac output to get blood to my muscles that are going to let me run or fight, right? And then my respirations are going to go up because I want to bring in more oxygen so I can do more work for a longer period of time. So my respiratory system is going to compensate to give me more oxygen so I can do more work. Okay, so talking about the drugs, we're going to talk about some drugs that you guys have learned this semester, and we're going to go through some of these receptors once now that we've talked about them, okay? I'm not going to talk about the adrenal sympathetic pathway because that's a pretty complicated one dealing with like diuretics and stuff. I believe you guys have learned some diabetic drug or some diuretic drugs, right? Like spironolactone, fluorazamide, acetazolamide, all that. Are those drugs you guys have heard before? Okay, I'm going to leave it up to you guys on your own to look up that pathway and to talk about how those work, okay, and where they're affecting this system, okay? So the third pathway, I got it up here on the graph, but I'm not going to show it to you. Has anybody got their feelings hurt? We all okay? Okay, really quickly, the sympathetic side here turns this stuff on, and the sympathetic side turns this stuff on. When the parasympathetic side is active, this side is asleep, and vice versa. Only one side can be on at a time, and it's kind of a tug of war between those two sides, okay? Is that fair? So if I'm in rest and digest, what is my lungs going to be like in rest and digest on the parasympathetic side? Anyone? Do I have to call on somebody?
Constricted.
Yeah, they're not going to be working as hard, right? Because I'm sitting at the table shoving my mouth full of food, right? I want to rest and digest. I don't need my lungs to work as hard, right? But let's talk about my stomach over here on the sympathetic side. If I'm on my sympathetic side and I want to go fight the bear, what's my stomach going to be doing?
Really nothing. It wouldn't want to digest at the time, so it would inhibit it.
That particular site in the sympathetic side is going to be shut off and not active. Okay, perfect. Is everybody kind of getting this? And is this helping you?
Yes.
Okay, so this makes sense. Okay, now we're going to move on. So here's a drug that you guys learned. Okay, this is a bronchodilator, and oh shoot, go back one, you cheap stupid thing. Okay, look at the MOA. Okay, what does the MOA say? Somebody read it out for us.
Finds to be adrenergic receptors in airway smooth muscle, leading to smooth muscle relaxation, bronchodilation, relatively selective for beta 2 pulmonary receptors.
So perfect. So we talked about, so this particular drug acts on what thing from our chart that we just looked over? What does this drug do?
Beta 2s.
It's going to be and is it going to make the beta 2s more active, or is it going to make them less active?
More
More?
active?
Yeah, they bronchodilate, making my lungs open up more, right? Going to increase the amount of oxygen coming in, right? And then they're selective, right? These beta adrenergic receptors, there's a couple other things that albuterol does, but the main thing that it does is bronchodilation. It also has some blood vessel stuff that it does. Okay, so does that make sense? So now listen, without looking at any other part of the drug card, what is going to be one of the actions that this is going to do? What is going to be something this is going to help resolve? Who would I be giving this medicine to?
Asthma patients.
Okay, asthma patients, right? And what's one of the side effects this patient could have? Without looking at the card, don't cheat. Think about the receptor. I've turned some stuff on.
Anxiety.
They're going to have some anxiety, okay? What about their mouth? Are they going to complain of their mouth being something?
Dry?
They could complain of their mouth being dry. Excellent, Alora. They could complain that they're thirsty. After you give it and we bronchodilate them and they resolve their asthma, a lot of asthma patients will say, hey, man, I'm a little thirsty, okay? Beta 1 and beta 2s are closely related to each other. Could this have some effect on heart rate?
Yes, there'll be
Okay. Thalen, what are we going to say? Say it again.
they're gonna be like shaking. My mom, when she would take that, she'd be like shaking.
Yeah, she gets the shakes, right? Because now look, this is the cool thing about drug cards. Right now, you guys are probably thinking, how do I remember all this crap? Guess what? If you know what the MOA does and in your mind, you know what the pathways do and what's turned on and turned off, guess what? I don't have to learn the side effects because now I just know what the side effects are because I know what this drug does by those receptors, okay? Is that cool? Okay. Who would be somebody I would not want to give albuterol to? Contraindicated.
Hypertension?
Yeah. Why would I not want to give it to somebody with hypertension?
Does it
Because
increase?
it would increase their heart rate.
Yes, it's gonna because beta 2 and beta 1 are on the same pathway. It is selective to beta 2s, but albuterol will affect beta 1s a little bit, and so you'll see an increase in heart rate. And for an already cardiac compromised patient, this is definitely contraindicated for them. And now you guys in first semester now know why that is, right? It has to do those pathways and who's related to each other. Okay, is there anything else you guys want me to go over? Did this help anybody? Okay, right here, ipratropium. You guys seen this one? We're gonna do this one quicker. Okay, what's its MOA? What's its action? What does it do? Right here, what's that word?
Inhibits cholinergic receptors.
If this inhibits my cholinergic receptors, then what am I gonna be in? Fight or flight or rest and digest? And Mindy's over here practicing with you. Mindy's what?
Fight or flight.
Okay, this is gonna push me into flight or flight, Alora. Why?
Because it's blocking the cholinergic receptors. So it's going over to the sympathetic.
Awesome. That's perfect. Thank you. That was a really good explanation. Okay, last one. Look at this one here. What does this one say? Laura, read this one out for me. What's the MOA for this one?
Decreases inflammatory response by stabilizing mast cells, which reduces the amount of histamine and other inflammatory cytokines release.
Now, guess what? Does this drug have anything to do with anything that we talked about previously? No, because it's talking about mast cells and cytokines. So if you don't know what mast cells and cytokines are, guess what your first assignment is when you walk out of here tonight is? You need to look up what mast cells are and how they are related to cytokines and what the role of histamine is. Because if you don't do that, you will never know what this drug does and how it works, and you'll be totally lost in the sauce. Okay, Kat, does that show you how Chris studies his drug cards, how I know and don't know what to go look for when I'm looking at my drug cards and what pathways I need to study?
Yeah.
Awesome. Did that answer all of your questions?
Yep.
Okay, anybody else have any questions with this before we move on?
So I had a question on our exam. We were talking about this in our study group a few days ago. Since there's beta 1 receptors in the heart, is there only the one beta 1 receptor in the heart?
So
Or are
remember,
there
beta receptors, right, are closely related to what? Lung beta 1s heart beta 1s and lung beta 2s are close to each other, right? but you will have drugs that selectively target beta 1, which means the majority of their impact is going to be on the heart, right?
Okay.
And if you have drugs that are selectively targeted at beta 2s, then they're going to
It'll be mostly
selectively
lungs.
target the lungs. But sometimes you get a little bit of spillover. That's why, like albuterol, it's primarily a beta 2 receptor, but it has some spillage, right? Where cardiac patients aren't indicated to give it because they're already cardiac compromised, and albuterol forces people's heart rates up. You'll find beta 1 drugs that contraindicate those in respiratory distress because they will influence the lungs and hurt patients that are already in respiratory distress. Casey, did that answer your question? Somebody, Bueller, Casey, you're on mute. Hit your space bar. Take your map. There we go. You're on now.
I can hear you. Yeah, that makes sense. Thank you.
Okay. So again, it's drugs, right? It's pharmacology, which means there's going to always, we can't control everything that the drugs are doing. Even as targeted as we are, we can't control everything. Okay, I'm done. Unless you guys got any more, I'm going to give it over to Cassie, who I need to make a contributor. Is it Cassie McFarland? Casey. Is it Casey McFarland?
Yeah.
It's Casey.
Casey, you are now a co-host.
Thanks,
But
Chris.
we'll click it for you. Hey, Jocelyn. Okay, I'll click it. You talk, I'll click.
Go ahead, Casey. It's all you.
I'm muting myself.
Do I share?
Do you share?
Okay. So would you mind going back one?
If you
Yeah,
need-
sure.
Oh, no worries.
You good? Okay.
Nah, this is good. Okay. Oh, would you mind going back one? Oh, perfect. Okay. So before I get started, do you guys know like the normal range of SpO2?
Type it
You
in.
can, you guys can type it in this chat.
Like 90 to 100.
Yeah. So normally it'll vary based on where you work. Where I work now, it's like 93 to 100. It'll range anywhere between 92 and 100 and 94 and 100. It also just depends on the patient. So what I really want to drill into, like before I get started, is like treat the patient first. Like if they're starting at 89, 90, but they have good skin color, they're not struggling to breathe, then you might want to do more assessments before you're just like, oh, here's 15 liters of oxygen. They may not need that. Okay. And then is he?
Chris. Chris, can you here? I'll pull up the PowerPoint really quick for you.
Perfect. Oh, he's got it.
You got
Okay.
it? Okay.
And so these are the common oxygen devices. So we've gotten, the reason we're going over oxygenation today is because we have our initial OSCE coming up, or our final OSCE coming up, and that involves oxygenation. And some of you guys are asking about that. So the ones that you mainly have to be familiar with is nasal cannula, simple mask, non-rebreather mask, bag valve mask. Those are the main ones. And we're going to go over what is the flow rate and when would you use them. Do you guys have any initial questions, like some that you aren't familiar with? You guys can speak up, talk in the chat.
I think so. With me, at least, I was kind of getting mixed up with like a simple mask and a non-rebreather.
Mm-hmm. So the difference is, we can pull up a picture later. I didn't include them because, I'm new at this. But so a simple mask is just the tube, the oxygen tube connecting to the face mask, and it gives a lower percentage of oxygen. A bag valve mask or a BVM, a non-rebreather mask has a oxygen bag attached to it. And before you put that on, you want to make sure you inflate that bag a half to a third full. That way they're not breathing in like empty air, and because that's not pleasant for the patient.
I want to add, Min, so you just hold in the mask, there's a little valve before the bag. You just put your finger on that and it'll fill up a little bit. But don't hold it too long because I've definitely popped it. So just be careful.
Yeah, normally half, third, that's you're golden. Okay.
Cool.
Awesome, thanks.
Next slide.
Okay, so the first one we're going over is nasal cannula. So you're gonna you're going to want to flow anywhere between 1 and 6 liters per minute of oxygen through that. So it's technically classified as a low flow device. It gives the lowest percent of oxygen. It's for patients with mild hypoxia, minimal to no respiratory distress. Normally it's for clients who need just a little something extra. So a lot of times you'll see this for like COPD patients or people who need like a little bit of extra on a regular basis. But also like if someone's statting like 90 or 89, then normally you can just throw them on, 3 liters of oxygen and it fixes it up to a good range.
Cool.
Do you guys have any questions about that?
I was just going to add, so when you're talking about like the percentage of oxygen, when you're hooking it up to the wall, it's always going to be 100% oxygen coming out or, out of the tank. But because of the device, that changes how much oxygen percentage you're actually getting. So because the nasal cannula is just in your nose, you can still breathe through your mouth. There's still air getting around. So the percentage is going to be lower. And then Ashley's going through the different ones. That's why the percentage is getting higher.
And do you guys have any questions about the FiO2 or like the percentage of oxygen that they're getting? So I'm just going to go over that just in case. So basically what it means is instead of 100% of the partial pressure of being oxygen, it's only like 24% oxygen that they're actually receiving. So it's a lower amount, so it'll have a lower impact on their SpO2.
Cool. Next slide.
Yes. Perfect. And the simple mask, this is another low flow device. So you're going to want to do anywhere between 5 and 10 milliliters or 10 liters per minute. And the reason that they're different liters per minute is just because a lot of times if it's too low, then the patient will have struggle breathing with the mask. But if it's too high, then it'll just kind of give them too much with the device that you're using. Perfect. And then this one is for clients with minimal to no respiratory distress. So who are like struggling to breathe a little bit more than a nasal cannula, or if they're like, I don't want to use a nasal cannula, then you can usually use a simple mask. And it's normally when their O2 stats are a little bit lower. It's just kind of a step up from the nasal cannula, if that makes any sense. And again, what this looks like, and we can pull up pictures after this, but again, what this looks like is it's just like a tube attached to an oxygen mask.
Next slide.
Yep, next slide. Perfect. And then this is the non-rebreather mask. So this is going to be for anyone who's experiencing moderate to severe respiratory distress. So it's going to be the step right below when you would use a BVM. So normally if you use this, you'll see patients in the tripod position with like their hands on their knees, like struggling to breathe, like, oh my gosh, you'll probably notice a little bit of anxiety in the patient. And so that's when you probably want to use a higher flow of oxygen. And because you would do that, you would use this device because it's at a rate of 10 to 15 per minute, liters per minute. And it does provide 80 to 90% of oxygen. So you can also use this when they're statting at, like low 80s, and it'll get you up to the high 90 range where you want to be. And then, like I said before, you just want to make sure you inflate the bag, like just by covering, there's this little nozzle in the bag and you just cover it and you make sure the bag inflates 1/2 to 1/3 before you give it. Otherwise, you're just making the patient breathe in a bag with no air in it.
And then the valves that are on the mask, you'll see them. That's why it's called a non-rebreather, because when they take a breath, they go out and they're able to breathe out the CO2 and then they close. So then when they're taking another breath, they're only getting that oxygen from the reservoir bag and the oxygen coming in. So a way to decrease the FiO2 is to take a valve off or take both the valves off, and then that's going to drop the FiO2. So just another tip. Cool.
Okay. So this one's bag valve mask. You guys should all be pretty familiar with this because it's the one that we do in the CPR training. So it gives, when it's attached to oxygen, it gives 100% oxygen. You use this if you find a patient in respiratory arrest or a respiratory arrest or like uneven breathing, but they still have a pulse. And that's what basically not breathing spontaneously is spontaneous is when they're breathing on their own. And then just, you know, if you find a patient lying on the floor not breathing, you know, and they have a pulse, then that's pretty much when you would use this. Do you guys remember how many breaths to give an adult per minute, or how soon to squeeze after a certain amount of time?
I think it's 10 to 12 breaths per minute, like 5 to 6 seconds. Like 1, 2, 3, 4, 5.
And a good trick that I learned is that if you watch your watch while you're doing it, so if you bring up like a counter like this, you can like count the seconds on it, and that way if you're in the moment and you're like freaking out, you can just watch your watch, and that way you're not going like 1, 2, 3, 4, 5. You're going 1, 2, 3, 4, making sure you're going the right rate. And then what about for a kid?
Every 2 to 3 seconds.
So it's actually every 3 to 5 is I think where the AHA, but as long as it's around
No,
12
you're right.
to
Yeah,
20.
I remember that. Yeah.
You're good. I had to, like, when I was making this, I'm like, is it 2 to 3? Is it 3 to 5? I don't really know. But yeah, so it is 3 to 5, so 12 to 20 breaths per minute, but aim for around 3 seconds.
Cool.
Okay, and these are just like other interventions that you want to include when people are having difficulty breathing on their own. So you're just going to want to reposition them. So if they're lying flat, you obviously just want to raise the head of the bed or sit them up, just kind of to, especially if they have fluid in their lungs. A lot of times if they're laying down, they can't breathe, but as soon as you sit them up, they have like no trouble breathing or very little trouble breathing. And then, yeah, so pretty much what you want to remember is oxygenate, reposition, and treat the underlying cause of whatever's causing their difficulty breathing.
Next slide.
Okay, and we decided to do a practice foundation scenario just because they didn't really go over with it like in depth a lot. They just kind of gave us the station and we're like, here you go. So this is the scenario that we chose. You're caring for an 84-year-old patient with a history of COPD and pneumonia. She was admitted into the ED earlier today with complaints of increased difficulty breathing. Your assessments reveal that she is using accessory muscles to breathe, has noticeable crackles in the left lower quadrant of the lung, and her SpO2 is 82%. What should you do first?
That would fall under like the non-rebreather, right? Because of the accessory breathing.
Yeah,
You'd
exactly.
want to position first, and then after position, then go to the mask.
Yeah,
Yeah.
pretty much simultaneously, I would think. Like sit them up.
Yeah, you can do it pretty much at the same time.
And what was the rate again? Like the liters per minute for the non-rebreather? Sorry.
10 to 15. Can we go to the next slide, actually? That's okay. Yeah. So first priority, put patient on oxygen. You never ever want to withhold oxygen, even if they're starting low, just give it. Because normally the only concern with over oxygenating a patient is for very like long periods of time. But if you're having if they're having trouble breathing, you just want to get it on them as fast as possible. But yeah, you would use a non-rebreather mask just because they are still spontaneous breathing. They're just having more trouble with it. And you wouldn't use a BBM because they're still breathing on their own.
Cool. Anybody have any questions?
So I guess my question, would you just automatically put it to 10 and then see how she's doing and then like adjust it up to the 15 if like you need, or I don't know, I guess my question is like, how do you know exactly what to turn it on to once you put it in, you know, like once you like
right
mask going?
Yeah. So normally I just go straight to 15 and then titrate down probably. But I just try to fix the oxygen. I would give as much oxygen as I could first to try to fix that O2. It also depends on, you know, what she looks like. If she's like blue or purple, then yeah, you probably just want to go for 15. And again, you never want to withhold oxygen. So you just can titrate down as needed.
Good question.
For determining which mask to use, I'm just like a very numerical person. Like, so for nasal cannula, would you say like 88 plus, 89 plus? Like, what's a numeric range you could kind of go off of for each of these?
Okay, that's actually a really good question. So normally if it's around 88 to like 90-ish and the patient's like, I need something to help me breathe, then you would probably go for a nasal cannula. But a lot of them won't tolerate the mask, so you use a nasal cannula if they're around that range as well. And a lot of times it's just easier. So it really probably I'd use it anywhere between like 88 and 90.
Hey, can I give just a little bit of advice for you guys for your foundations exam? So if you have an oxygen problem on a foundations exam and they need oxygen, you cannot make a mistake unless you do nothing. So if you put a nasal cannula on them and like say they're at 78%, you put a nasal cannula on them. The only way that you can fail that is to put the nasal cannula on and put it to 10 liters, right? You actually do the intervention incorrectly. But if you put the nasal cannula on correctly at the correct rate, then the nurse preceptor or the examiner, if it's critical for the scenario, they will tell you, hey, this patient is now at 81% and they've been on it for 5 minutes. Would that be an appropriate response for what you want, or do you want to be more aggressive about it? Right? And that's your decision. So then you might say, that's not what I want to be at. They've only come up 2% in like 5 minutes. Then you'll say, oh, you know what? I'm just going to go right to the non-rebreather mask. I'm going to put that sucker up to 15. And then again, when you reassess their O2 sats, because you'll keep doing that throughout the scenario, then your nurse preceptor will say, oh yeah, it's been 5 minutes and they're now at 98. Then you say, hey, I'm going to turn this down a little bit because that jumped really quickly. This patient responded very quickly. As long as you choose the correct intervention with the right O2 level for that mask or that intervention, you will not be wrong. Does that make sense? Is that good advice for everybody? Kind of take the stress level down?
For sure.
Okay. I'll let you guys. Casey's doing a great job though, so I'm gonna shut back up.
I do have a quick question about the scenario with the COPD, because I learned, I'm sure you guys kind of remember from patho with COPD, they were like, don't go too fast with oxygen because it kind of turns off their natural O2 drive or something like that.
Yeah, so normally COPD patients normally stat around 88 to 90. So you just kind of want to ask them what their baseline is, and also just treat the patient if they're having extra trouble breathing. You probably just want to keep it at that range, at their normal range.
Yeah, I think the biggest thing for this scenario is that it's 82. She's using accessory muscles. She's obviously struggling to breathe. And so you can always decrease the oxygen, right? So if she's blue and struggling to breathe, you don't want to make her struggle for longer by only giving her a little bit of oxygen. Give oxygen and then turn it down, because it's mostly prolonged high levels of oxygen that you're worried about with those COPD patients.
Okay, I was just wondering because she said to start at 15, so I was like, oh.
And we have EMT mindsets too, because
I know
we're 15 liters non-rebreather, but like Chris was saying, I don't think you can mess up in this scenario. I think they want to know moderate distress, you want to give a higher level of treatment.
No, you will only get in trouble on your foundations exam if you do nothing to correct an O2 problem, or you set your interventions to the wrong later, then you'll fail. If you choose an intervention that's appropriate and you set the intervention and put it on the patient correctly at the right level, you will not fail. Does that help you out, Laura?
Yeah, it does. And it makes sense to titrate down, if it jumps too fast, then just titrate as needed.
I also think with COPD patients, if it was hey, you have a patient who has COPD, they came into the clinic for something else and you took their O2 stat and it was 89, you wouldn't be and they usually sit at that, then you wouldn't treat them for that or for if that's their baseline and they're not having issues breathing, because then you can kick off their normal breathing or their secondary breathing, like you were saying, with the what they usually run at for COPD. But since this one is they're in distress, then that's when you're going to want to go up. But guys, I just remember they said don't.
The intervention makes sense. It was just kind of a side question.
Yeah, and a lot of the time, if COPD patients are receiving oxygen, in the hospital setting, they're going to be managed by a respiratory therapist and be using those Venturi masks. If you remember learning about that, with the different whatever they're called, pieces to give them a
percentages.
What's that?
Oh, it controls the oxygen percentage.
Yeah, exactly. I don't remember what the pieces are called though, but they're color coded. And so I don't know. I don't think that's obviously it's not something that we're into yet. So cool. Any other questions? I think that was the last slide on oxygen stuff.
Yeah, the only other slide, it was just if you have any questions about any like potential scenarios, because I know I'm a very like I like to think in my brain like, oh, like if this would happen, what would I do in this scenario? So if you guys have any questions about like possible scenarios that you're curious about, like how you would manage that with oxygen, like what you would use, please feel free to either ask that in the chat or now, or just message any one of us.
I have one question. I can't remember if they're below, say it's like somebody who like overdosed or something, or they were breathing on their own, but their respiratory rate was like a 6, then you would still use a BVM, right? Even though they're breathing on their own just to assist them. Okay, I just wanted to double check. I couldn't remember.
Yeah, if it's low or they have irregular breathing, yeah, you'd want to help them out. And a lot of times if they are at 6, they're kind of not super with it. They've altered mental status as well.
Okay, cool. Thank you.
Cool.
Will we get to have those PowerPoints?
Yeah, we're gonna post them after this on the website that I've shared with you guys a couple times to do those NCLEX questions. I'll share it again right here in the chat.
Thank you, Jocelyn.
Yeah, we're gonna put all of our stuff up there so you guys can go back and we'll do the recording there too. Everything will be on that website.
Thank you.
Yeah. Awesome. Any other questions before we move on? No? Okay, cool. All right. So I didn't realize that you can only like get 10 people to join for a Kahoot if you don't buy it. So the first 10 people to log in can play the Kahoot. And then whoever doesn't get on there, just answer in the chat. So let me pull it up really quick. Give me a couple seconds here. I've never done this before. So we're all learning together.
We have Professor Jones.
Yes. All right, let's see. Let me screenshot.
For the record, I hate Zoom.
It's not the best. It's not the best thing here. All right, cool. So if you want to get out your phones, I think 10 people can join. First 10 people get to be on Kahoot.
Hey, Jocelyn, we'll talk about how to get it to where you can get more people on there.
Do you have like a...
Yeah, there's a way to get to where you can do it.
Cool. Two more. I don't even know if it will probably stop at 10. I don't know. Never done it. Work in progress. Cool. Uno más. Maybe. Boom. All right. Let's start. At home. All right. Okay, so what is the primary intracellular cation? And if you're not on Kahoot, you can throw it into the chat. Wait, can you guys see my like pictures on my screen, or just the Kahoot? You can just see
the Kahoot.
Okay. All right, cool. So yeah, potassium is the primary intracellular cation. Sodium is a primary extracellular cation. So that's something that's going to always come back because it's very, like cellular, and a lot of drugs will affect the different cations. So cool. Any questions about that? All right. Next question. Ooh, Swahili. All right, let's go. All right. Atropine and scopolamine work by blocking what receptors in the parasympathetic nervous system? Is it nicotinic receptors only, muscarinic and nicotinic receptors, muscarinic receptors only, adrenergic receptors? Which one? Atropine and scopolamine. Oh, we're close. Yeah. So, what was the question? Yeah. So it's the, postganglionic, the muscarinic, acetylcholine blockers for that one. Cool. Any questions before I press the next one?
Is it because like the muscarinic that's the one receptor that is like for both parasympathetic and sympathetic,
So
crosses over?
preganglionic, all preganglionic neurotransmitters use acetylcholine,
Right.
but postganglionic is the muscarinic receptors for the parasympathetic nervous system.
Okay.
So when you think muscarinic, think parasympathetic.
Okay.
Yeah, nicotinic is all of them.
All of them. Okay. Thank you.
Yeah, no problem. Oh, cat moving up. Cool. All right. Next question. A drug will be completely metabolized by the first pass effect. What change will need to be made during administration? Will the drug need to be given more frequently? The drug must be given parenterally. The drug must be given in higher doses, or the drug must be given in lipid-soluble form. Okay, cool. So the right answer is parenterally. So the first pass effect, if you guys remember, that's being metabolized by the liver. So if it's completely metabolized by the liver, by the first pass effect, it's going to not have any effect after that because it's completely metabolized. So the answer for it is it needs to be given parenterally, which is IV, sub-Q, all that stuff. Any questions about that? Cool. All right. Oh, I don't even know how to say it. How do you say your name? I don't want to say it wrong.
Talini.
Talini. Okay. Talini's moving up. She's on fire. Look at that. All right. Let's go. All right. Next question. Why must grapefruit be avoided while taking certain medications? Is it because it's nasty? Because it is. Its acidity inactivates the drug. It causes you to excrete the drug more quickly, or it interferes with metabolism of the drug. All right. So yeah, it interferes with metabolism of the drug. Does anybody know how?
Doesn't it deactivate the CYP enzymes?
Boom. Yes, 100%. That's exactly why. So by deactivating the CYP enzymes, what does that cause? Like what happens with the drug?
Isn't there like more available or like free drug in your blood?
Yeah. So CYP enzymes are metabolizing it to be excreted. So if it's interfering with those CYP enzymes and the ability to metabolize it, then you're not going to get rid of it at a normal rate. So then you're going to build up levels in your blood. So then it can become toxic. So toxicity, grapefruit, because it's making you, have more drug in the body without it being metabolized properly. That makes sense. Cool.
Can you give examples of the drugs that we're seeing that have that happen to them?
Yeah, I think one of the ones we've learned is the statins, like atorvastatin, simvastatin, all those ones for cholesterol. That's the one I can think off the top of my head. But yeah, I think
there's like certain like antidepressants, I think too.
Yeah. Yeah, put me on the spot. I don't remember anything other than the statins, but I know a lot of different drugs can affect those. So it's a good thing to be mindful of the drug cards we have when we get that kind of thing as patient teaching. So cool. All right, getting some. Oh, look at them, still in the lead. Highest answer streak. Let's go. All right, number 5. A patient with asthma is prescribed inhaled fluticasone and inhaled albuterol. How will you administer these medications? Will you first administer fluticasone and then 5 minutes later administer albuterol? First administer albuterol and then 1 minute later administer fluticasone? First administer fluticasone and then immediately administer the albuterol? Or first administer albuterol and then 5 minutes later administer fluticasone? I did not give enough time, I feel like. So sorry. Okay, awesome. Yes, that is right. Can anybody tell me why?
Because albuterol's a rescue drug.
Yeah, sure. What? Absolutely. And what does it do?
It bronchodilates. Is that what you're asking?
Yeah, exactly. And then what is fluticasone?
Corticosteroid.
Perfect. So why would you want to give albuterol before you gave the fluticasone?
Because that takes the steroid takes a little bit longer to work. It takes a longer time to kick in.
Yeah, for sure. And then the one thing that I was thinking with this question is if they have asthma and they're bronchoconstricted and fluticasone, you want it to get into those, air sacs in order to decrease the inflammation. So if they're constricted and you give the fluticasone first, it's not going to get all the way into the air sac. So you want to be able to bronchodilate and then give the corticosteroid. And that's why it's 5 minutes later, so you can give it time to work.
Right.
That makes sense?
Yeah.
Cool. All right. Next question. Ooh, sorry. I did not look at the leaderboard. I'm sorry. Okay. Dextromethorphan is a antitussive, mucolytic, expectorant, or a decongestant. Do we have 9 people on Kahoot now? We have 10. Let's see. Okay, let's see. Right answer is antitussive. So anybody can tell me how dextromethorphan works?
Works directly on the cough center, right?
Boom. Yes. And that's why it's a antitussive and not any of the rest of those. Cool. I think the next question is also about this. Let me go to it. Oh, nice. Swahili's in the lead. Wow. Okay. Next question. So an antitussive like dextromethorphan is indicated in which of the following? Is it to encourage removal of secretions through coughing, relieve a dry cough, relieve rhinitis, or control a productive cough? I feel like the 20 seconds is so fast. All right, perfect. So yeah, it's a relieve a dry cough because all it's doing is stopping that cough reflex. So it's not doing anything with secretions or productive cough. It actually would be contraindicated in that because if you stop the cough reflex, you're not going to be able to cough at any of that junk that you need to get out. That makes sense? Cool. Any questions? We still have a lot of questions. Okay, I'm going to keep going. All right, you're teaching a client with microcytic hypochromic anemia about their diet. Which of these should be encouraged? Eggs, cheese, lettuce, or grapefruit? Okay, so we're kind of, gotcha. So the correct answer is eggs. I guess my first question is, what kind of anemia is microcytic and hypochromic?
Iron deficient.
Yep, exactly. Because you're not having the iron in the cells, so they're going to be small, and then they're going to be hypochromic, means they're not as tinted, or whatever word you want to use for that. So eggs and like animal products are going to be high in iron, so you want to encourage thing, or iron fortified like bread, cereal, that kind of stuff. Lettuce. I wonder why you guys are thinking lettuce. Why is people thinking lettuce?
Honestly, I think I like just thought there was a lot of iron in lettuce, and I don't even know why.
I think a lot of vegetables actually do have iron, but the correct, like the more orange answer
Is eggs and like
yeah, exactly. Because animal products, they also have like iron in their blood, I believe. So then that's gonna have higher.
No, that makes sense. I was like, shoot, I know it had something to do with iron, so I was debating.
Yeah, I don't know how much iron is in lettuce, but there
I
might.
have no idea. So with the eggs and the cheese, that's like dairy too. So is it
Yeah.
just because eggs has more?
I think the reason why cheese would be incorrect is because if you remember, you want to give iron with vitamin C, and you don't want to give it with calcium.
Oh, okay.
I
Yeah.
feel like the calcium in the cheese would probably counteract any iron that's already in it.
Right. Okay, that makes sense.
Cool. All right. Do you guys want to keep going to get through all the questions, or do you guys want to hop off at 8? You can hop off whenever you want to hop off. If you have any requests for what we cover in the next meeting, just let me know. I think, do you guys want to do another one in a week? Do you guys find this helpful?
Yes.
Yes.
Yes. Cool. Awesome. Glad to hear it. So yeah, I guess we'll just plan 7 to 7 p.m. work on Monday next week for everybody.
That should work.
Awesome. Okay. Anybody have any requests for what we cover next time?
I think so. This is my first
Community.
time, but do they have the other people that were here? They were like second semester, right?
Casey's in our group, but Chris is in second semester, yeah. And Mindy as well.
And he's gonna be there next week too.
Yeah, for sure. Yeah, me and him are like the co-chairs of the education committee. So
Okay.
whatever you want him to know, I can help relay that. Or
Okay.
if you want him to
I
cover
guess I was just thinking with the head to toe OSCE, maybe if
Mhm.
you have like any tips about that.
Okay. Yeah, we can definitely ask that. And then I would for sure, if you they're doing like a whole like one-on-one mentor thing with next Tuesday with the
that's
mentoring.
right. So maybe
Yeah.
that'll just be fine just to go to that
I mean,
then.
that's gonna be like active feedback, but I can ask him to give everybody his tips too.
Sure.
Cool. All right. Anybody else? Nicole said immunity.
Yeah, like how they figure out the pathways, because I struggled in class today.
Yeah, that little chart that we had to do, if we could go over that maybe.
Okay. Yeah, I struggled too. I was like, oh.
Yeah, she said submit what you can, and I was like,
I was like,
I have 2 sentences. Okay, thanks.
We're all feeling the same. Cool.
And then I never saw the key, so.
Yeah.
Yeah, I haven't seen it either, so we should be fine.
All right, we can do immunity. Cool. And if anybody thinks of anything else, just shoot me a message. All right, let's finish these questions. Oh, nice. Getting some changes. All right. A drug that has a positive chronotropic effect. Why does that go so fast? Strengthens the force of cardiac contraction, accelerates the heart rate, speeds up cardiac conduction, or constricts the cardiac arteries. So it accelerates the heart rate. Yep. And then, so strengthens the force of cardiac contraction. That's going to be the inotropic. A really weird way that I remember it is I just feel like if I'm getting mad, I'm like, I know, and I'm getting madder and madder and madder. So that's inotropic, the strength of the contraction. Chronotropic, I think it's like Latin or something, but chrono means like time, like chronological. Think chronological. That's going to be the time. So chronotropic is the heart rate, like accelerate or decelerate. Dromotropic is the conduction of the heart. Cool. All right. Next question. Toxicity from which of the following medications can cause a client to see a green halo around the lights? Is it furosemide, metoprolol, digoxin, or enalapril? Nice. Everybody got it. Yeah, this is one of those questions. When I took my paramedic exam, they were like really weird about digoxin too. But yeah, that's one of the toxicity things you'll see is like blurry vision, halos around the lights. So cool. All right. Next question. Which of the following causes or drug classes protect the ischemic myocardium by blocking catecholamines and SNS stimulation? So which of the following blocks catecholamines and SNS stimulation? Beta adrenergic, calcium channel blockers, narcotics, or nitrates? So the correct answer is beta adrenergic receptors. Calcium channel blockers, they are like indicated in like heart problems, but the key word here is blocking the catecholamines and the sympathetic nervous stimulation, which is going to be the beta adrenergic. Calcium is channel blockers are blocking the calcium, which may have an indirect effect on those, but not directly like the beta blockers would. Cool. All right, Rosie's moving up. Let's go. All right. Cough is the most common side effect of which of the following antihypertensive medications? Losartan, nifedipine, hydralazine, or lisinopril? I just realized there was music. I don't know if you can hear it. So yeah, correct answer, lisinopril. Anybody know the class of medication lisinopril is?
ACE inhibitor.
And where's ACE? Where's the angiotensin converting enzyme located?
That's in the lungs, right?
Yep. And that's how I remember that. That's like one of the most common side effects that people will complain of after being put on a lisinopril, which is like common medication, is they'll get this chronic dry cough. And I don't think it's actually necessarily anything to do with the ACE enzyme being in the lungs. I don't think they know the exact mechanism by why it causes a cough, but that's how I remember that it's the ACE inhibitors that cause the cough. So a lot of the time they'll probably change them to an ARB like losartan. Cool. All right. Oh, look, 3 in a row. She's coming back. All right. Which is a class of I can't even see. Block potassium channels. Is it 1A, 4, 3, or 1B? Okay, we're a little over there. Okay. Yeah. So honestly, I looked this one up and I had to look it up. I didn't even know it, but I thought it would be a fun thing to throw in there. So the class 3 is the things like amiodarone, which are potassium channel blockers. And then if you saw that picture right there, it delays repolarization by blocking the potassium from getting out of the cell. So I don't know how I think that's phase 3 of the action potential. And that's how I'm going to remember it from now on. But other than just like memorizing the classes, I don't have a good way to remember that one.
Okay, so like the first class is like sodium, right? And then it's like beta, then potassium, then calcium.
Yep.
And then the first class like further divides into like the ABC.
Yep.
Right?
Yeah, and they're all sodium channel blockers. They just block sodium differently or different.
Right. Okay. Good refresher.
Yeah, exactly. I thought it would be a good thing to throw in there to like confuse everybody because it confused me. So, okay, cool. All right. Look at that. Okay. Only a couple more. What is the antidote for heparin? Is it protamine sulfate, flumazenil, vitamin K, or Narcan? Oh, wow, you guys are fast. Yes, protamine sulfate. Flumazenil is the antidote for benzodiazepines. Vitamin K is for what?
Warfarin.
Yes. And Narcan, opioids.
Opioid.
Perfect. I thought I'd trick somebody. I didn't trick anybody. All right. You guys are too smart. All right. Number 15. Oh, see image. Sorry. This is a long question. I'm sorry. Polyethylene glycol golightly is being prescribed to your patients, begins to experience diarrhea following administration. What action by the nurse is appropriate? Start an IV infusion, administer an enema, discontinue the medication, or explain that diarrhea is expected. I'll get better on timing. But yeah, golightly it's prescribed to cause diarrhea. It's like a colonoscopy prep, one of the most common ones. Miralax is another form of polyethylene glycol. So you guys are great. It's so smart. All right, I think I have like 3 more. Older adult patients taking Bethanechol urocholine need to be assessed more frequently because of which adverse effect? Tachycardia, dizziness, hypertension, or urinary retention? Ooh, okay. Does anybody know what Bethanechol is? Well, I'll tell you, it's prescribed for urinary retention. So it's actually like I think it's the beta 3 adrenergic, what is it? Beta 3 something. Anyway, it activates, so I put the brand name in there, urocholine, because it stimulates the cholinergic or the parasympathetic system, so then they're able to urinate more frequently because they're having urinary retention. So because of that, that's why it's crucial to know like the parasympathetic effects and sympathetic effects, because if it's activating the parasympathetic effect, what is the parasympathetic effect on the heart?
Slow down.
Slows it down.
Yeah, exactly. So they have to be careful with orthostatic hypotension, because they're being parasympathetic stimulated, if that makes sense. I don't think they really talked about this one, but I saw it on a drug card, so I wanted to throw it in there. Cool. All right, just a couple more. A patient is taking NPH insulin every morning. The nurse knows that the most likely time for hypoglycemic reaction to occur is 2 to 4 hours, 16 to 18 hours, 4 to 12 hours, or 18 to 24 hours. I can't talk anymore, I'm sorry. All right. I know we just barely learned these, but I thought it would be a good thing to throw in there. What type of insulin is NPH?
24-hour. Intermediate.
Intermediate.
Yep. So I think like the biggest thing that we're going to need to know is like the time for like rapid acting versus short acting versus intermediate versus sustained. So the peak of administration after that is about 4 to 12 hours for the intermediate. Whereas the sustained, you're thinking of, there is no peak with like Lantus. They take it once a day, but there's, that's just a constant level. So cool. All right, one more. Get out of here. Ooh, she moved up. I still don't even know how to say it right. I can't even think it. I'm not even gonna try. See image. Sorry, I messed up again. All right, your patient's blood glucose level is 215 milligrams per deciliter. The patient's about to eat lunch. Clear sliding scale, you administer 4 units of insulin Lespro at 11:30. As a nurse, you know the patient is most at risk for hypoglycemia at what time? 11:45, 12:30, 14:30, or 16:30? I need a lot more time. I'm so sorry. Okay. Okay. So it was insulin Lispro. Anybody know what type of insulin that is?
Rapid acting.
Yes. What's the peak? What's the peak time? Well, it's rapid acting, right?
Like an hour?
30?
Yeah.
30 minutes?
30 to 60 minutes.
Okay.
There we go. I think it's actually an hour, but because then that would be
study those.
Either way. 11:45 is only 15 minutes, so it's still wrong. I think it's 30 to 60 minutes. So yeah.
What's the rapid acting that's like right away?
That's pretty much right away. Let me see if I have it pulled up. So Lispro is what the one was onset is like less than 15 minutes, but the peak is 30 to 60.
Oh,
minutes
okay, that's
after.
where I was mixed up. I think because I did the 11:45, and I think I was thinking of the 15 minutes there.
Yeah, so
Yeah.
it'll work in 15 minutes, but it'll peak in that 30 to 60 minute range.
Okay, that makes sense.
Cool. Should we see who the winner was? Let's see. Dun dun dun. In third place, Miranda. Nice. Second, Thaylin. Is that right? No. Thaylin or something. Sorry. And Swahili. Nice. Rosie, Tessa, runner-ups. Awesome. Cool. I hope that was helpful for everybody. Thanks for coming. Makes my life easier when my work is shared. So I hope that was helpful. Let me know if you guys have anything other than immunity that you want to cover next time. Cool. Any questions? What did you say? Sorry.
Thank you. I appreciate it.
Thank you. Thank you
A lot
guys
of
for
work
coming.
for both
Thank you, Joss.
You're
Thank you,
welcome.
Jocelyn.
Thank you. Thank you guys for being here.
Thank you.
Yeah. Happy. Okay. All right. We'll see you next Monday, 7 p.m. Everybody have a good night.
Yeah.
See ya. Good job.